Wow. Those of you who know me know my father-in-law was an Irish immigrant to this country, and were he here, he would introduce me differently. What he would say to you is this. He'd say, "I'd like you to meet my son-in-law Dave. He's a doctor, but it's not the kind does you any good." So I'm quite honored by that introduction by Cheryl. I want to begin by noting that my quest to understand what promotes healthy child development began at home. My wife, Maureen, let's make sure I can do this. Not really. There she is now. And my wife, Maureen, and I have been working on our marriage for 42 years. We're still working on it. We've got two kids, Quinn, who's 31, and Nora, who's 26. We wanted those kids to be productive members of their communities, who had strong families and friendships, who didn't abuse drugs, who didn't engage in violent behavior. I think it's what all parents want for their children. And it's really an honor and a privilege to be here today to talk with you about progress over the last 30 years in understanding how communities and families and schools can be more effective and successful in promoting the healthy development of young people across this country. This School of Public Health has a wonderful motto. It says, "Good health is infectious." And I just want to take a moment to say that your dean is infectious. Cheryl Perry has done more to prevent smoking and drinking among teens and young adults than any other living person I know. From the first time I met her, which is longer ago than I'm allowed to tell you, she has inspired me with her vision, her ability to turn that vision into preventive interventions that are appealing to young people and their families, and her scientific rigor. As we've learned today, she is the voice of the Surgeon General on preventing tobacco use among young people. But not just Cheryl, your whole school is infectious. You've pioneered school-based obesity prevention through the CATCH program that Deanna Holscher and Steve Kelder and colleagues continue to enhance and disseminate across the state of Texas. You've integrated school programs and community-level programs into interventions that are showing significant effects in reducing overweight and obesity among low-income children in the state of Texas. It's really exciting work that's going on here. And the ideas that I'm sharing today are derivative. They are applications of prevention and health promotion pioneers, including Cheryl Perry, Guy Parcell, and the talented faculty of this school. I'm deeply honored to be among you. And as a social work faculty member, I am also happy to see your dual social work and social and public health master's degree program. It's very exciting to see. I wasn't always a professor at the University of Washington. Before that, I was a probation officer. Now, when I say before that, I'm reminded of one trip to Ireland Maureen and I took some years ago. We were in County Roscommon. We were visiting her family, the Mahan clan, and they didn't have a telephone in those years, and so they knew we were coming at some point in time. They weren't sure when we'd be there. We arrived at the door. We knocked on the door. Mrs. Mahan opens the door and she says, "We're so glad you've come home. Come on in." We never met these people before, and soon we were talking and eating and drinking, and musical instruments got out, and at some point Maureen says, "Now, what about Uncle Jack? Isn't there an Uncle Jack Mahan?" And Mrs. Mahan says, "Oh, yes, your Uncle Jack. He's gone to town in the donkey cart. You go up on the road, you'll see him. He's coming home soon enough now. Go up on the road, you'll see him." So we went up on the road, and sure enough, there's this elderly man being pulled by this little donkey in a little cart coming towards the house. And Maureen starts up to him and says, "Hello, Uncle." And she says, "You're Kathleen's daughter." And she says, "Yes." And she says, "And who are you?" He says to me, "Who are you?" And I said, "Well, I'm David Hawkins. I'm Maureen's husband." He says, "And where are you from?" And I said, "Well, I'm from the United States." And he says, "Before that?" And I said, "Well, all my life I've lived in America. I'm an American." He says, "Before that?" And so we began tracing our way back through the Hawkins lineage to Kentucky. And every time I'd start in Virginia, every time I'd stop, he'd say, "Before that." So finally I said to him, "Well, Uncle Jack, as far as I know, Hawkins is an English name from the southwest of England and County Cornwall." Uncle Jack Mahan never spoke to me again. It's a true story. He turned from me. He never had another word for me. God rest his soul, he's passed from the earth now. But it reminds me how easy it is to fail to communicate across cultural boundaries, even when you're members of the same family. I'm here and I do the work that I do because I'm committed to the healthy development of young people, regardless of what cultural or ethnic or racial or gender background they come from. Before that, I'm committed to the healthy development of all young people. I should have been smart enough to say, well, before that, Uncle Jack, I was a probation officer. Maybe I could have thrown him off the scent. But I wasn't wise enough to do that. I will tell you that as a probation officer, I felt like I was running an ambulance service at the bottom of a cliff. We could help these kids kind of get patched up, but every day the judge would refer several more kids to us, and we'd have to try to help them turn their lives around. And I began to ask the question, isn't there something that people should have done before this point, before we have to help these kids figure out that it's not the best thing to rip people off and get loaded and so on and so forth. And so I really became very interested in the concept of prevention and thinking, should we be able to prevent these problems before they happen?
I need to resolve something if you want that video to play.
Oh no, it's not the video yet.
Yeah, I know, but it won't play unless I do something quick.
Okay. Well, so I got to the University of Washington. And when we got there in 1980, we had an opportunity in a research group that I was in to review all the delinquency experiments, prevention experiments that had been done in America up until that time. There had been 9 true randomized experiments in which people were trying to prevent delinquency before it happened. And you can't use your audience cueing thing right now, but you're supposed to be able to, so we'll just do it this way. Out of those 9 experiments before 1980, how many of them do you think were actually, well, we're back to there. I can get there. So 9 of them were conducted before 1980, and the question is, how many of those do you think were actually effective in preventing delinquency as of that time? And you now have 5 seconds to answer. None of them. 0. None of them. Did you get that answer? You didn't have that opportunity, did you? Oh, 6. Oh, it is. 52% got it right. I'm learning the technology too. Sorry. Okay, so most people got it right. None of them had been shown. If I were here today telling you I know how to prevent delinquency in America, and it was 1980, you should throw me out of the room, because there was no evidence that we knew how to do that at that time. People who were concerned about substance use prevention were also evaluating their programs, and most of those programs in the 1970s were not effective. In fact, the programs that provided information about drugs and the risks of drugs were actually shown in some studies to be associated with an increased risk of drug abuse. The doctors who do you good have an adage. They say, above all, do no harm. And if we're trying to talk about preventing a problem before it happens, then we above all must do no harm. And that led my partner in research and I, Rick Catalano, to start to look around and say, who's been effective in prevention? And lo and behold, we found this field called public health. Cardiovascular disease prevention, heart and lung disease prevention. And they had done something very straightforward. They'd done a longitudinal study in a place called Framingham, Massachusetts, and they'd identified predictors of heart and lung disease, what we now call risk factors. And if I were here today talking to you about predictors of cardiovascular disease, what are risk factors for cardiovascular disease, what would you say? Just shout them out. Smoking's one. Diet, overweight, high blood pressure, stress, sedentary lifestyle, family history. Some of these things are not in our individual control, but a lot of these are lifestyle changes. And as a result of understanding those risk and protective factors, ain't nobody smoking in this room here today for a really good reason. It's not good for your health or the health of the people around you. We've had a sea change in lifestyle associated with understanding the risk factors for cardiovascular disease. Today in America, if you don't exercise, at least you feel guilty. We know we're supposed to do it. So we said, why don't we take that same approach in trying to understand how to prevent the problems that we're concerned about, like delinquency and substance abuse among young people. And so our work is based on a simple premise. If you want to prevent something before it happens, you need to understand what are the predictors of that something. We've had really two major advances in prevention science in the area in which I work. First is this new knowledge that's come from longitudinal studies of what are the risk factors for adolescent health and behavior problems like delinquency and violence, and what are the promotive or protective factors that reduce the likelihood of those things. And secondly, there have been a plethora of studies that have carefully evaluated preventive interventions based on this knowledge of risk and protective factors that seek to reduce risk and enhance protection, and we now have a menu of test and effective prevention programs from which communities can choose. So first advance, understanding the predictors. I don't mean they're necessarily causal, although some of them are, and also the predictors of well-being or positive outcomes in young people, which are called protective factors or sometimes promotive factors. They promote health. I don't know if you can see that chart. I hope you can. Across the, along the columns here, what you're seeing is outcomes that we were concerned about in our own work. And down the rows, what you are seeing are factors that in 2 or more longitudinal or high-quality epidemiological studies have been shown to predict the outcome at the intersection of a row and a column. So if there's not a check in that column, it doesn't mean it's definitively not a risk factor, but if there is a check, it means that that's a risk factor for that outcome. And if we were able to change that risk factor, to reduce that risk factor, that we might in fact see reductions in the outcomes that you see. This is in fact trying to identify a menu of possible targets for preventive intervention. There are some risk factors that exist within the neighborhood or the community context in which people grow up, but there are also risk factors within the family, within the school, and with the individual and peer group. Now, we began our work in focusing on substance abuse and delinquency, but as we began to look further, we found that a number of these same risk factors were also predictors of a number of other health and behavior outcomes of concern to people, which means that if, for example, there's a risk factor there called family management problems. There are really 3 components to this. When parents fail to set clear expectations for their children's behavior, when they fail to monitor their children in developmentally appropriate ways, and when they are excessively severe and inconsistent in discipline, those 3 characteristics are what we consider to be family management problems or poor family management. In families that have those characteristics, children are at risk for all of those externalizing problem behaviors where you see checks. So if we could just help all the parents in Austin do a better job of setting clear expectations for their children's behavior, monitoring their children in developmentally appropriate ways, and being consistent and moderate in their discipline, we could be reducing risks for a number of health and behavior problems. I'm not going to spend more time reviewing these except just to notice that a number of these risk factors predict a range of health and behavior problems in young people, which got us to start thinking if we're going to address risk factors, we better measure multiple outcomes to see if in fact we could be preventing a wide range of health and behavior problems in young people through a risk-focused prevention approach. We also found in these longitudinal studies that there are promotive or protective factors that to some extent characterized individuals. High intelligence or resilient temperament. My children, Quinn and Nora, as far as I know, are peas from the same pod, but they have different personal temperaments. Quinn, I could yell at Quinn and 15 minutes later he'd say, Dad, let's go outside and shoot baskets. But if I were talking to my daughter Nora as loudly as I'm talking to you right now, she would say, my dad's mad at me, I'm going away. And she would go in her room and hide from me because she would think it was just too stressful for her. She doesn't have this kind of a resilient temperament. Competencies and skills, the skills of social interaction, the skills of how do you say hi to another young person and meet them and make friends with them, these are skills that people learn. I remember when Nora was about 5, we were going on vacation, and she said, Dad, while we're on vacation, will I be able to play with other kids? And I said, well, sure, Nora, you could play with other kids. She said, but how would I meet them? And I said, well, Nora, if you saw someone you wanted to play with, you would say, hi, my name's Nora, what's your name, would you like to play? She looked at me, she said, you forgot something. And I said, what's that? And she says, how old are you? And I said, well, where does that go? And she says, you say, hi, my name's Nora, what's your name, how old are you, and if they're about your age, you can play with them. That's not the second or third question that you ask people at my age, I will assure you. But these competencies and skills are developmentally adjusted over time. You need different skills as you get older. And if people have those competencies and skills as they develop, that actually helps protect them against the kinds of problems we're talking about. But there are also characteristics in the social environment that make a big difference. Opportunities, reinforcement, bonding, clear standards for behavior. And in our own work, as Cheryl mentioned earlier, we've tried to integrate this knowledge of what are promotive or protective factors, factors that promote well-being in children, into a model that's as simple as fingers on one hand. If you have either of your hands with 5 fingers, you can remember this model. And this is one thing I would hope you would take with you. If our goal is the healthy behavior of young people, I think we need to start to think about how do the social units in which young people grow up provide them first with appropriate opportunities for active participatory involvement. That means when an infant is at home with mom, that mom picks up that infant sometimes, doesn't just leave that infant in the layette all the time. Because picking up an infant in your arms is an opportunity for active involvement. When you're a first grader, if sometimes you get to feed the gerbils, that's an opportunity for involvement, for active involvement. If only those smart kids who are doing really well get to feed the gerbils, then you don't get any opportunity for active involvement. If you're a 4th grader, if the teacher never calls on you because she doesn't think you have the skills, then you don't have opportunity for active involvement. If as a middle schooler they're building a new park in your neighborhood, but you don't get to say what should be in the skate park or in the playground, then you don't have an opportunity for active involvement. I hope that's making sense to people. The second thing that people need is to ensure that young people have the skills they need in those opportunities. That's number 2. So when mom picks up the infant, if the baby goes, ah, 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 that's a skillful performance, right? If in this first grade I feed the gerbils and I water the gerbils, have the skills to know that I'm supposed to feed them and water them, that's a skillful performance. You get the idea. When that baby coos, mom says, oh, do you see she cooed to me? That's bonding. That is the gyroscope of bonding, a connection, emotional connection that develops between that mom and that child because that mom reinforced that cooing. In the first grade, when I feed and water the gerbils and they're running around in the little spinning cage, and the teacher says, wow, look at the gerbils, how happy they are. Dave fed the gerbils and watered them all last week. Didn't he do a great job? Class, isn't it great that Dave did and fed and watered the gerbils? Whose turn is it this week? That's recognition and reinforcement. And how does Dave feel after that happens? He says, I kind of like this class. Those are great gerbils, and I got a good teacher, and I like being here. Opportunity, skills, and recognition build a sense of community, a sense of bonding or connectedness between young people and the people in their social environment. You know, and so that's what we think happens. Bonding develops. And when young people feel bonded to a social unit, whether it's their family or their teacher or a big brother, big sister, a person in a boys or girls club, that bond provides a very strong motivation to live according to the standards for behavior offered by that group. Many, many years ago, Mrs. Reagan said, just say no. Well, just say no is about standards. But just say no isn't enough because unless kids feel bonded to the people who are promoting those standards, they don't care about the standards. So if I hate my teacher and my teacher says, you really got to do your homework, I don't care. But if I did that gerbil thing and I got a lot of feedback to the teacher and the teacher says, and remember you've got 15 minutes of reading to do tonight, I'm probably going to do it. So one last thing, there are individual differences. How do you reinforce my son Quinn? You tell him, great job, Quinn, and you slap him on the back. Nora, you can't say that to Nora directly, at least when she was a younger child. I had to say to Nora's mom, Maureen, did you see Nora got perfect grades? And Nora would be listening to that, and she'd hear that reinforcement, and she would recognize that reinforcement, and she'd say, I like this family, it's a good place to be. So the point that I'm trying to make is, if in the interaction with young people that you have, or that you work with teachers who work with young people, if you can just keep these things in mind, opportunities for active involvement, make sure they have the skills to be successful in that involvement, recognize and reinforce skillful performance in a way that people can accept it. That'll build bonding. And then making sure that the standards that promote healthy behavior becomes a fundamental part of this 5-piece social development strategy. So that's the promotive or the protective side of what we're trying to do. And I would like you to just watch this and see if you can see in this momentary interaction between a mom and a child, opportunities, skills, recognition, bonding, and healthy standards for behavior. A development of a commitment of that young lady, of this young lady, to a way of life.
Is 6 orange plus 8 blue. How many is that altogether?
14.
You got every single one right. Are you good at math?
Yeah.
You are good at math. Do you like doing math?
Yeah.
Yes. Okay, let's do a different one.
Did you see it? So opportunity for involvement. She did a skillful performance. She could count them up. She didn't know how to add 6 plus 8 to get the right number, but she counted them up and she got it right. And the mom says, "You got everyone right," and they slap hands. That's reinforcement. And then she says, do you like doing math? Yes, I like doing math. There's no sexual stereotyping with that little going on, at least in that interaction. And then she says, "Are you good at math?" "Yeah, I'm good at math." That's a commitment to doing more math in the future on the part of that young lady. So what people have been saying, and a number of people have been saying, is we need to reduce those malleable risk factors and increase those malleable protective factors that we know are associated with healthy outcomes in young people. And in fact, a number of people, including our own research group, have been doing preventive trials that show that when you reduce risk and enhance protection, you can have positive effects on a wide range of behaviors. In a project we did in Seattle, the Seattle Social Development Project, we've seen effects on alcohol use. From a social development intervention in the elementary grades, we've seen positive effects on reduced alcohol use, on violent behavior, on sexual risk behaviors, on mental health problems in the 20s, as well as on economic outcomes in high school graduation. So it's possible to really have big impacts on the development of young people, the healthy development of young people, by reducing risk and enhancing protective factors. And in fact, there are now a range of test and effective programs that have been shown to be effective for preventing a number of negative outcomes or health compromising outcomes that we see. And so it is really a different place than where we were 30 years ago. And these slides, these 2 slides are taken from my colleague Rick Catalano, who's just worked with a group, an article that'll be coming out in the Lancet in the next few months on what does work for prevention among young people. So that's the pretty good news. And again, I'm afraid you may not be able to see this cost-benefit information, but people who have been doing cost-benefit studies have found that, in fact, you produce a positive benefit for every dollar you put in. I think that's nurse-family partnerships. Can people read it? You can read it better than I can. So for every dollar you put into nurse-family partnership, you get $3.23 in return in terms of reduction of child abuse and neglect, and later problems of the children in the criminal justice system, et cetera. And you can just see that there are a number of preventive interventions that now are showing positive benefits, and that they cost less than the benefits that they produce for society. And that's really a big sea change from where we were in 1980. And we've also learned that a number of things don't work. Scared Straight, even though it's on A&E and you can go home and watch it, and the next week Scared Straight's still on television, but it doesn't work, and in fact it's iatrogenic. There have been studies that show that those kids that go and get yelled at by the lifers are actually more likely to commit crimes in the next year than kids who are assigned to just go through a regular probation thing. So we know some things that don't work as well as what does work. If you're interested in the list of tested and effective preventive interventions for young people, here are 3 sources for what I think are some of the best lists for evidence-based prevention programs. And yet, in America, maybe with the exception of Catch in Texas, we are not doing very much use of evidence-based prevention programs in our schools and in our communities. And that really got us to be quite concerned. And we began in our own work, instead of just doing school or family-focused interventions, we began to say, how can we work with communities? And we really think that the challenge was to increase the use of tested effective prevention policies and programs, while recognizing that communities are different from each other, and nobody wants to be told what they have to do. People want to make choices for themselves of what would be the best thing to do for our community. So, this is one of those questions. How many of you work in the community on public health prevention or promotion? 76% yes, 24% no. Do you believe communities should decide which programs should be used in their area? That is, it could be up to the local community to make that decision, or should be up to the local community to make that decision. Yeah, me too. So 92% say yes, it should be up to the local community to make that decision. So what do we know about how we could help influence or inform those decisions? Well, one thing we know for sure is that different communities are different. They produce different profiles of risk. This is a school in Seattle, Washington. It's a middle school in Seattle, Washington. We surveyed all the 8th graders in the school. 87% of them took this survey. And what you're looking at in these bars is the prevalence of being at high risk on that specific risk factor in that youth population. So that's the profile of Madison Middle School. Go across town in Seattle to Nova High School, where my wife taught. It was an alternative high school, and you see a very different profile of risk. Different risk factors are elevated in different schools. And that means that if we wanted to affect the prevalence of health and behavior problems in those schools or in those different communities, we might want to choose different preventive interventions. And so we began to think that a goal for community level efforts to seek population level effects, is to identify those risk factors that are most prevalent in a community, most elevated in a community, and try to reduce them, identify the protective factors that are lowest in the community, and try to enhance those things by using tested and effective programs. That led us to develop an operating system for prevention. Just like with our computer, you need an operating system to get to the right application. Communities of Care is like an operating system for communities to get to the right application for their particular community set of needs. It helps by starting by building community coalitions, coalitions of all the key stakeholders in the community who care about the well-being of young people. They assess and prioritize risk and protective factors, and I'll tell you more about how they do that. They then match their priority risk factors, the risk factors they say we need to address, and the protective factors they say we need to strengthen. They use preventive interventions that have been shown to be effective in addressing that specific set of risk factors and in improving behavioral outcomes. And we then, through communities of care, help them support and sustain those preventive interventions, whether policies or programs that they've chosen. So how does it work? We actually survey all the kids in the public schools in the 6th, 8th, and 10th grades in communities that want to use the communities of care system. Those surveys are repeated every other year in those communities to measure progress in risk reduction and enhancement of protective factors and outcomes, so that you can monitor your progress on an ongoing basis in communities of care. And we think that because this is owned and operated by local communities, not by somebody someplace else, that it will lead to greater sustainability in maintaining this scientific-based approach to prevention. So let me just get to the bottom line. It works. I'll tell you more about it, but first let me just tell you it works. It's been tested in a randomized controlled experiment that we've done, 12 pairs of matched communities across the country from Washington to Maine. And it's also been independently replicated in a quasi-experimental study in Pennsylvania done by the Penn State University. And these are the outcomes that we see. In a panel of children we started following when they were in 5th grade, by the time they're completing the 8th grade, they're 33% less likely to start smoking cigarettes than the kids in the control group, 32% less likely to start drinking alcohol, and 25% less likely to start engaging in delinquent behavior. If you look at the current prevalence of those behaviors in the 8th grade, you see significant reductions again. And the one that's probably the most interesting is 37% less likely to binge drink. That's 5 or more drinks in a row. About 9.5% of the control group 8th graders say, I've done that in the last 2 weeks. compared to about 5.5% of the kids in the CTC communities. So communities of care has been shown to be effective in this controlled trial. And I want to just tell you now about how it works. The first phase of communities of care, we say communities of care is bottom up and top down. We don't think you can do it one way or the other. We want the community leaders, we want the people who control resources and shape opinion. The mayor, the police chief, the school superintendent, business leaders, media leaders, health leaders. We want those people to understand what communities of care is and to make a decision about whether they want to bring that into their community or not. Because later on, the coalition that's working on this is going to come back to them and say, you know what, we got to change how we spend some of our resources in youth programming. And they better be bought in from the beginning to say, yes, we buy into this process. If they say this is the right approach for us, and if it looks like it's the right approach for them, then they move into the communities of care process. Now, what keeps people from doing this? Well, I would say, for example, if the mayor, or let's do it this way, if the police chief and the school superintendent in your community won't ride in the same car to go listen to an orientation to communities of care, it's not right for your community. There has to be a basic level of willingness to collaborate for the well-being of young people, or else things aren't going to work well together. But if there is a basic sense of collaboration, and if people are willing, the residents in that community are willing to work with service providers, then you have a foundation for doing it. If the people in the community say, oh, child welfare services, that's what takes our kids away. Juvenile justice, that's what takes our kids away. Then you need to do some work in that community to get people willing to believe that the future is possible and that people can work together for the future, residents as well as people who control resources and provide public services, before this is appropriate for the community. In that first phase, the community leaders make that decision, and if they say yes, they then either identify an existing coalition or they create a coalition with key stakeholders from all the stakeholder groups in that community in this second phase, and they get oriented towards communities of care. And just to give you an idea, in the trial that we did, there are 12 experimental communities, and these are the people who are represented on those coalitions in those 12 communities. So you can see there's a real diversity of stakeholders, and that's exactly what we want. We don't just want school and public health people. We don't just want law enforcement or child welfare. We want everybody who should care about the well-being of young people on that coalition. Once the coalition is formed and has gotten its original training, then they develop a profile of the risk and protective factors as well as outcomes in their community. It's done using something called the Communities of Care Use Survey. The survey is in the public domain. If you go to the website at the bottom, you can get the survey as well as the item construct dictionary for the survey and how to score it. And it provides quite valid and reliable information in a single class period on all the major risk and protective factors that we think we can measure in a survey, as well as on youth outcomes. So this is that Nova High School where my wife used to teach. This is the outcome. These are the outcomes from the survey of the 10th graders in Nova School. About 79% of them took the survey. And what you're looking at here, how many of those kids said they had been drunk or high at school in the last year? 52%. Over half the kids in this school say they've been drunk or high at school in the last year. If you look at the proportion of kids who report they've ever used alcohol, it's about 86%. This number here, this little diamond that you see, is the prevalence of that behavior among 10th graders in the National Monitoring the Future survey conducted in exactly the same year. So if you're in this school and you're a member of the coalition that's trying to reduce problems in the school, you're seeing that you've got almost a 15 or 16% higher rate of ever using alcohol in this school than in the country. Marijuana use, about 40% of 10th graders in this year had used marijuana use. In this school, it was over 70%. So when people saw these data, they said, that's a problem. We're concerned about substance use in our school, and we need to think about doing something about it. There were children, students, as well as parents, faculty members, service providers, administrators of the school. When they looked at the protective factor profile of this school, they saw something that was very interesting. This is an alternative school. It's a school where kids develop their own program and get to pursue their own interests and work in the classroom and beyond. And look at this, the proportion of kids who say this school provides opportunities for pro-social involvement, remember that? that from the social development strategy, it's almost 100% of kids in this school saying, this is a wonderful place of opportunity for me. These are kids who've been kicked out of or left or got out of regular schools and are now in this alternative school. It's also a wonderful place of recognition for those kids. They say, yeah, they recognize me when I make a good effort, when I improve, when I do well in school. But look over here at social skills. These include skills to reduce or to refuse offers from friends of trouble. These kids aren't so good at that. Only about 42% of those kids have refusal skills that are equivalent to what they need, compared to about 60-some or 50-some% of kids in the general population in the Seattle Public Schools at that time. These diamonds now are for the Seattle Public School District. So this team said, maybe we should be working on social skills with these kids. Emotional and social skill development may need to be one of the foci of what we do. When they looked at the risk profile of this particular population, favorable attitudes towards drug use were expressed by about 95%, or I'm sorry, about 85% of the kids in that school, of the 10th graders. So most 10th graders in that school, whether they were using or not, or had used or not, said, what's the big deal if kids use? A lot of kids use in this school. It's part of what people do in this school. So that became a focal risk factor for this team. They said favorable attitudes towards drug use is a risk factor that we should be concerned about. They also saw that perceived parental attitudes favorable towards drug use was another risk factor that was elevated. So they were saying the kids in this school are coming from families where parents think it's okay to use drugs, and they're thinking it's okay to use drugs themselves. So they then go to the next strategy, which is they choose which risk factors they want to reduce, which protective factors they want to strengthen, and then they begin to create a plan to do that. In Communities of Care, there's a menu in this Prevention Strategies Guide. There's a menu that says if this is your risk factor over here, then here are programs or policies that have been tested and shown to be effective in reducing that risk factor. And here are grade levels at which they've been shown to be effective. Do they also promote these social development strategy constructs? And they see here that classroom curricula for social competence promotion looks like something they should look into. When they go to the Prevention Strategies Guide, they will find these and a number of other tested and effective preventive interventions that have been shown to address those risk factors of favorable attitudes, as well as skill development, and have been tested in well-controlled trials and shown to have positive effects on drug use. Oops, sorry. They go down here. Where am I? Go back, go back. They go down here and they say Project Towards No Drug Use. Where was that tested? That was tested in alternative schools in Los Angeles and high schools to boot. And this is an alternative high school. They said, let's look at that program. And the more they looked at the program, they said, this is the program we want, because it's been tested in the very same kind of school that we are and with positive effects. And so that's the program that that particular school put into place. They then formed task forces to oversee the implementation of the 2 to 5 new programs that they've chosen to put into place, to implement them with fidelity, to look at the quality of the implementation, and to monitor that. I'm not going to spend much time today talking about monitoring fidelity of implementation, although tomorrow on the webinar, hopefully we'll get to that topic. 6 trainings to get this in place. First, the key leaders get oriented, and over the course of the next several months, it's about a year process to get to the point from you say, we're going to do Communities of Care, until you're about ready to implement and evaluate tested effective programs and strategies. So it takes about 6 to 9 months to do the assessment and get to the point of choosing the strategy that you're going to implement. At a year, you should be implementing the new programs and policies. We think in 2 to 5 years, you will see change in risk and protective factors, and in 4 to 10 years, you will actually see community-wide effects on problem behaviors of young people. So I think we go to a little time. I'm going to stop yelling at you for just a minute and ask you to just pair up with the person next to you and just listen, think about what you've heard so far. What questions come to mind? I want you to hold on to those questions. We're going to get a chance to talk about them. But what are you wondering about at this point? And do you think this could produce better outcomes for children in communities that you know? So just talk to the person next to you for just a second or two. Okay, I'm going to ask you to come back together now, if I could. So I have another one of these things. We have another one of these things. Could it work in communities you know in Central Texas? And the answer is, it could work. Good, I'm glad you think that, because I do too. So let me just tell you, I know time is limited now, and I need to get to just sharing with you the study a little bit more. The study was done in these states, matched communities within each state, randomly assigned either to get communities of care or not get communities of care. 24 incorporated towns, matched and randomly assigned. We've been following this panel of 4,407 kids through grade 10. The communities got those 6 trainings over 12 months. They collected survey data, just as we said, prioritized risk factors, implemented tested prevention programs from the CTC menu on an average 3 community new programs, but not per year, 3 new programs that they would then sustain over a period of several years. They chose the programs from a restricted menu for this particular trial. The community care menu of programs goes from nurse-family partnerships for pregnant teenagers all the way through multisystemic therapy for kids who are adolescents with behavior problems. But we restricted the range here to programs that affected kids in the 5th through 9th grade because we had 5 years of NIH funding to try to see if we could see effects from this intervention. And so it's a little bit more limited menu for this particular intervention. What you're seeing here are the programs that people chose in the 1st year of intervention, the 2nd year, and the 3rd year of intervention. These yellow ones are school-based programs. These are after-school programs, more secondary prevention, or more what we would call selective prevention for kids who are at higher risk because they come perhaps from a single-parent family or having academic difficulties in school. And then these are the parenting-focused programs. And one thing I would like to just see you, ask you to notice is that in the 1st year of intervention, even though there were school people on these teams and on these boards, only 6 of the school districts that were in this study in the communities of care intervention condition actually implemented a new school-based program in the 1st year of intervention. But because there was a coalition in their town working on promoting healthy development of young people, and those school people were going to those coalition meetings, over time the coalition people kept saying, you know, we're good, we're starting to do these things in the community, we're working with parents, but we really need to have school-based programming as part of this. And what we see is that by the 3rd year of intervention, all 12 of those experimental districts had, in fact, a school-based curriculum in the schools. And that led to a big change in program exposure. There are about 10,000 kids who were eligible to be intervened with across these 24 communities in grades 5 through 9. As you look at those kids, you see about 1,400 of them were reached by school-based programs in the 1st year. By the 3rd year of intervention, half of them are being reached by intervention that's tested and effective preventive intervention. That led us to believe that perhaps we could begin to see effects on the whole community, not just on people who've been through a specific program, but on all those kids in the panel that we're following for the 5th grade. We weren't particularly disappointed by this number because these were selective interventions for higher risk kids. We were terribly disappointed by this. We weren't able to mobilize those communities, to mobilize parents to come out in the same numbers that we would have liked to see parents coming out for prevention. That's still a nut that we, at least in our group, haven't been able to crack very successfully. So the communities targeted locally specific sets of elevated risk factors, 2 to 5 risk factors each year. And what I'd like you to do is look down. This is a community 1, 2, 3, 4, those are the 12 experimental communities. And you can see that different communities chose to focus on different risk factors. The risk factors are listed over here. You can see some risk factors are common across communities, but many communities chose different risk factors. I think this is one of the keys to success of communities of care. We get to choose which risk factors we think we can make a difference in, that we can impact and change, as well as the protective factors that we can change. And when we compare the risk factors targeted by a specific community with those same risk factors in their matched control community, what we learn is that by the end of grade 8, you're seeing a higher increase in risk in the control communities than in the blue CTC communities. Now, risk exposure grows up between grades 5 and 8. More kids have more friends who use drugs, more permissive parents, more opportunities to get access to alcohol and tobacco, etc. But what you're seeing is that this line goes up more slowly in the CTC communities, and by the 10th grade we see a significant, by the 8th grade we see, I'm going to make sure, a reduced significant slope, and the mean difference at grade 8 isn't statistically significant at the 05 level, but it is at a p.064. So the question is, what does that produce in terms of outcomes? Among the 8th graders who hadn't started smoking by 8th grade, 12% of them started smoking in the 8th grade in the control communities compared to 8% in the CTC communities. In the 8th grade, in the control communities, fully 25% of the kids who hadn't started drinking in 8th grade in those control communities compared to 17% in the CTC communities. So when you hear of a 33% drop in relative prevalence, that's what I'm talking about now. That's the 33% drop from 12% to 8% initiating in the 8th grade, from 25% to 17% initiating in the 8th grade. And we found significant effects on delinquency actually beginning in the 7th grade. When we look at current alcohol use in the panel, you can see no significant differences at baseline in grade 5, but by the end of grade 8, significant reductions in the prevalence of current alcohol use, binge drinking in the past 2 weeks, and delinquent behaviors committed in the past year. When we follow those kids up at the end of the 10th grade, which is a year after the experimental intervention on our part ended. So now these communities are on their own, and we put ourselves into a situation where he said, we're not going to help them for a year. They're on their own for the next year. Let's see how they do and whether they can sustain the programs as well as the effects. And when we look at that panel a year after the intervention that we were involved in stopped, but the communities hopefully are still doing those interventions, we see these kinds of changes. All of these are significant findings, and they just are out in Archives of Pediatrics and Adolescent Medicine, I think maybe this month or last month. And this is just looking at ever smoked. 52% in the control group had smoked by the end of 10th grade compared to 44% in the CTC communities. And if you look at the likelihood of starting smoking in the 10th grade, you see an adjusted odds ratio of almost half. So almost half the likelihood of starting to smoke in 10th grade in CTC communities compared to control communities. Similarly, with the proportion of ever drank alcohol, 3/4 of the control kids have had alcohol compared to 2/3 of the kids in the CTC communities. And again, a significant reduction in the likelihood of starting to initiate in the 10th grade, as well as with delinquent behavior. So, and similarly with violent behavior. So we're seeing continued significant effects even after we're out of the picture, with these communities continuing to do the work with their own young people in their own community, maintaining and trying to sustain these interventions. When we have done a cost-benefit comparison, if you're interested in this paper, it's just out this month in Prevention Science, we see that the cost of this is about $1,100 per kid to do this program. Under the most conservative estimates, we have some very small communities, there are fixed costs in this, and so that increases the cost per child. But using the most conservative estimate of cost per child, you see the cost is about $1,100 per child. But the delinquency benefit, just in terms of the prevention of delinquency, is netting over $4,900 in reduced cost to society because of reduced juvenile justice processing, having to put kids in institution, et cetera. And the smoking benefit itself is almost equal to the cost of the program. We haven't in this included monetization of the alcohol benefit yet, although we'll do that in the future, which means that for every $1,100 you get a net, that you spend, you get a net benefit of $4,700 basically, which yields about a $5.30 benefit for every dollar that you invest in communities of care. So we think it's a good investment, and we're very excited about these findings. If you're interested in community care, the operating system was purchased by SAMHSA, the Substance Abuse and Mental Health Services Administration, in 2005, and they put it in the public domain. And the easiest place to find all the materials, the training materials, the PowerPoints, everything else to implement community care is that first website, www.communitysecure.net. There's also a thing that NIDA has done that's a little town hall meeting that you can see some communities that are participating in community care and what they say about it. And I guess the last thing I would just like to say is that I'm pleased that the federal government has purchased community care and has put it in the public domain. But I'm worried because the federal government is not currently investing in the level of training and technical assistance that really is needed to help communities put this in place successfully and effectively in our judgment. And so if you're interested in community care and learning more about it, or how can we get training and technical assistance, or how might we pursue this idea, Blair Brooke Weiss from our group is the person who is the contact person if you're interested in learning more about it. And with that, I thank you very much for your attention.